Yes, yes, yes. Welcome to another episode of Hip Hope Hooray, Men Talking Health. I am your MC for this evening, or should I say today. I am Oya Gilbert, and we have a really boss program for you today. In the building, I have one of the most esteemed, or one of the top esteemed men in the hematology space, oncology space. I got Dr. Craig Cole, who is a board certified hematologist who received his Bachelor's of Science degree in physiology at Michigan State University and the College of Linmar Bridge. I hope I'm pronouncing that correctly. Received his doctorate degree at the Ohio State University College of Medicine and completed his residency and fellowship at the University of Michigan. Additionally, Dr. Cole conducted post-fellowship laboratory research at Jerome Lipper Multiple Myeloma Center of Medicine and the Dana-Farber Cancer Institute / Harvard Medical School. Man, this dude's done a lot. Currently, Dr. Cole has expanded his work in myeloma research and clinical care at Carmenos, I hope I pronounced that, Carmenos Cancer Institute in Detroit as an associated professor at Wayne State University School of Medicine. He is a member of the American Society of Hematology, International Myeloma Society, European Hematology Association, and International Myeloma Work Group. Now, look, y'all, all I can tell you is the dude is just super dope. And I want to welcome, that was a mouthful. I feel like I need to go get some water and take a break, go to a commercial break. But Dr. Cole, it is an absolute pleasure to have you on my show. You are an absolute rock star when it comes to myeloma and those, and especially in the Black and Brown communities. Welcome to the show.
Well, thank you, Oya. I appreciate it. You just pronunciated everything on point.
Okay, I was struggling there for real. My whole education level was tested, at just reading your bio. But today we're going to talk about something that can literally change the future of medicine, but only if everybody gets invited to the table, and that is clinical trials. For decades, our community has been told they're important, but nobody ever really explains why they matter, why we're missing from them, and what happens when we're not represented. And so that's what we are going to talk about. And in this episode, we hope to, Dr. Cole, in our conversation, we hope to debunk some of the theories that folks have, especially in the Black and Brown community, about clinical trials. But before we do any of that, I just told you what his bio was. So, Dr. Cole, Craig, can I call you Craig? Dr. Cole, what
please, you can call me Craig.
Okay, all right.
The name I was born with.
So, speaking of being born, the young Craig Crow, when he was growing up, what made you fall in love with medicine before you even knew what multiple myeloma was?
Yeah, my dad was an engineer. He got colon cancer when I was when I first started high school. He died when I was 16. Then my grandfather, that lived right down the street from us, he got prostate cancer, and he died about 2 years later. Jeez. And then when we buried my grandfather, my grandmother, who was LPN, who had been an LPN in the past, and who was taking care of my dad and taking care of my grandfather, when we buried my grandfather, she said, "I have colon cancer." And so I went off to college, and I talked to her several times a week, and I had a job up in college, and she said she was doing okay. She's doing okay. And then when one day she calls me down to say, can you take me to my doctor's appointment? And I was like, sure. I skipped class, came down, and she was in rough shape. I mean, she was lots of pain. Took us a half hour to get her down the stairs. She had so much pain. I had to drive a little slow to the clinic because she had so much pain. Then we finally got to the doctor's office. The doctor barged in, didn't knock, um, and called her by her first name and said, Vesta, your cancer's worse. You're going to start a new chemotherapy tomorrow. Started walking out the door. My grandmother said, you know, no, I don't want to go on hospice. I've had enough. And her doctor turned around and just threw every insult that there was at my grandmother, calling her every name in the book and just saying she was, saying how she was stupid, she didn't know what she was talking about, she wasn't going to help her. And my grandmother just looked at me and said, and she's yelling. My grandmother, turned to me and I'm devastated. And she says, take me home, son. And so, we walked out of the office and packed her up. I was packing her up in the car. And when she had her arm around me and I'm putting her in the passenger seat. And she said, son, I think you can do a better job than that lady taking care of people. And I said, yes, I think I can do a better job than that. And so changed my major, and so since, halfway through my freshman year of college, I was committed to being a physician. And really, the core of me being in medicine is about patient empowerment, because my grandmother was empowered enough to say what she wanted, despite what her doctor said. She had friends, she put herself on hospice. She died comfortably, thank goodness. But yeah, that's how I got into the game.
Wow. Every great superhero has an origin story. And my friend, that is a powerful one indeed. Definitely shout out to your, sleep in peace to your grandma. If not for that, it sounds like you wouldn't even be in this space. And certainly all the good that you have done so far and will and hopefully continue to do. And being as though you're a Black physician, walking into rooms where very few people look like you, what responsibility do you feel beyond simply treating patients?
Yeah. There's a lot, but it's an honor. There are Black doctors that have come long before me that have not, I don't want to say towed the line, but have carried the flame. And have brightened the flame and have really tried to push things forward. And you can, look at, especially Charles Drew. Despite all the things that he faced, he continued to hold himself with grace and kept his eye on the mission ahead, which was to improve the care of patients. And so I do. I know that, from medical school, through all my training, I'm always aware of that. I look into a room and I'm just like, okay, wear your bow tie, walk in. My grandfather always said, walk in looking good, because the eyes are going to be on you. And that's true. And so, but it's not only looking good, but it is, speaking the truth, speaking, the not only, my truth, but still, everything that I do, the words that come out of my mouth when I talk about myeloma, health equity, it is all about bringing up, people. And it is all about, changing things. And so, it is an honor to carry that flame, to carry it on and brighten it.
Man, I thank you for that. And if y'all don't, for the viewers, one thing I want y'all to know about Dr. Cole is, he mentioned, he grazed over real quick, but he said the bow tie thing, right? This dude here, let me tell you, he's got an assortment, a plethora of different bow ties, but that's his I would say his fashion statement, because you won't rarely see him without that bow tie on. And Craig, I want to go into, let's bust up some of the myths
Okay.
that go along with clinical trials. When people hear clinical trial, what's the very first myth you wish would disappear forever?
Yes, that's easy. Is that they'll receive a placebo, that they'll receive something less than the standard of care. And when we have asked people about, we've done several surveys
Mm-hmm.
in the Black community, and the placebo keeps coming up.
Mm-hmm.
And the trick about placebos is that when placebos are part of randomized trials where you're trying
Okay.
to test one treatment against another. But the one treatment has to be the standard of care. And you cannot. There are so many to open up a clinical trial. There's so many safeguards that have to be passed. It has to go past the FDA. It has to go past a review board. It has to go past a local review board. And if there's any hint that somebody will receive less than the best available care at that time, then that clinical trial cannot go through. And so when someone receives, and randomized trials are standard of care versus new treatment, which is usually standard of care plus something. And if
Yeah.
it's standard of care plus something, then they're getting, 2 pills. And if someone's getting the standard of care, then they may get, 1 pill plus something else, placebo.
Got
But
you.
you will get the standard of care. It is against the law to give anybody in the United States to give
Right.
someone less than a standard of care in a randomized trial. You will get the best care.
I'm glad you said the point of it's against the law. One of the things when I have spoken to folks that are on the fence, they might bring up Tuskegee or something of that nature,
Mhm.
and I try to be very, very respectful of their thoughts and that, because that really, it happened, and I'm not going to discredit that. But I also try to let them know this is 2026. They have laws in place now. You just can't be just doing things
Yeah.
all willy.
Oh,
And so that's why I'm glad you brought up that component that it's illegal. I
yeah.
mean, to be doing the things that maybe, as you state, have people thinking, oh, that's why I don't want to do a clinical trial. I want to say, if my auntie, because I've heard this before, so if my auntie asks, am I going to be a guinea pig, how would you answer
My mom asked me that.
her? No.
She was going to go on a clinical trial. Yeah, her son is a clinical trial doctor. And she said she was going to go on a blood pressure clinical trial. And she
Okay.
said, am I going to be a guinea pig? And I said, there is no pill that will turn you into a guinea pig. It cannot happen. It is impossible. But to your point, there are no guinea pigs.
Yes.
There are no guinea pigs. When a new drug is being tested, it has to go through, in the United States, it has to go through such rigors to assure safety. It goes through, and it's, when you talk about Tuskegee and you talk about, a lot of the errors that were made in the past, a lot of
Mhm.
those errors that happened in the past have informed us today of how to do safer clinical trials. And so
Mm.
Tuskegee, what happened to the indigenous people, a lot of these other things where there were horrific things that happened to people. The flower off of that is that we now know what to do to make clinical trials safe. And one thing that we learned to do is that you have to test, and retest before you ever put a new drug in somebody. And then if you're actually testing a disease, that drug has been gone through multiple hurdles to get there. And so,
Right.
and they're drugs that never make it. They're drugs that never make it because they're too toxic, they're too dangerous. And so are people guinea pigs? Is it the first time that this drug has ever been used in anything living? Absolutely not. No, we don't mess around. I mean, we don't, the primary point, I think one myth is people think the primary point of the clinical trial is the drug or the drug regimen. The primary point of the clinical trial is to assure safety. That's
Oh,
what everyone is zeroed in on. They're
okay.
zeroed on. I got a bunch of clinical trials running right now. And the thing that I by far spend the most time on, hands down, is safety, 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 safety. I
I
get
love
4 or 5 emails a day of safety, 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 safety. And so, and I hear when I'm doing clinical trials, I hear about something, somebody ate a bad salad on the other side of the country on a clinical trial. When they had diarrhea, I found out about it because just in case somebody thinks that it could be, somehow related to a clinical trial.
I
And
got
so
you.
safety is the primary point of the
Paramount.
clinical trial.
I
And
got
so
you.
are people guinea pigs? There's no time where clinical trials have been safer than they are today.
So, what surprises patients? What do you think surprises patients the most after if they can get past that? What do you think they surprises them most about joining a clinical trial?
A couple of things. One is how much support they get and how they have, when you see, your average patient on a clinical trial, they have me and they may have the nurse that I work with, every few, when things come up. But really, it's primarily me. If you're on a clinical trial, you have me, you have a research nurse that talks to you regularly. You have my clinic nurse who talks to you regularly. And then you have a whole army behind you that is looking at your safety. You have a clinical trial coordinator, you have the sponsor of the clinical trial, you have all these people that are looking out for your safety and making sure that the drug works. And so they're a bit surprised at how their care improves and how they get so much attention that they really enjoy. I have patients that go from clinical trial to clinical trial because they love the access that they have to the health system.
The best
and
of the best.
And to me, because we're keeping such a close eye on things.
So clinical trials, is it true, or is it true that they're only for people who ran out of treatment options?
Oh no, that's a good myth to bust. No, I mean, especially these days, clinical trials have been moved closer and closer to the upfront setting because
Okay.
the medications are being discovered these days, and the science is so good that we no longer hold out these drugs for the last option. We now move these drugs closer to upfront because we see how well it works. And why would we have somebody wait, 10 years to be on a clinical trial? We can do it tomorrow. And so we have clinical trials for people who have a few options, but primarily we have clinical trials for people who are newly diagnosed, who have their first relapse, for people who are on maintenance therapy, for people that have, that aren't being treated at all. And we're trying to figure out some of the science behind it. We have clinical trials for, every step of the way. Because what we want to do is we just don't want to, it wouldn't make any sense for us just to improve the people that are, that run out of options. We approve everything along the way. And that's kind of the key to it. That's a very good point. That's an old, 15, 20 years ago, that was true. 2026, no. everywhere.
Got you. Thanks for thank you for busting that. Earlier we talked about, we know Tuskegee happened, Henrietta Lacks. There's medical racism. I guess when someone says I don't trust clinical trials, I guess, are they wrong? I know, but I guess are they wrong to think that for those reasons? And I think you answered it earlier, but I guess, are they wrong to have that skepticism in today's time?
I think that skepticism, healthy skepticism is always welcome.
Okay.
Harmful skepticism, when you start closing doors that have been opened, then that becomes a problem.
Ooh.
Healthy skepticism, when somebody says, I want you to be on a clinical trial, and you should ask questions. You should be skeptic 100%. You should ask, what is this going to do? What is the point of this clinical trial? What is this? What is that? You should have skepticism 100%. But should you immediately say no, closing a door on options that you have? I would not let the skepticism get that far, because there was a day when we weren't asked about being in clinical trials. There was a day that we were coerced into clinical trials.
We wasn't even allowed in some of these hospitals, some of these institutions.
And this is a different day. Thank God, this is a different day. And so you can't. I'll tell you, what has me worried more than anything is when someone, and this happens every blue moon, somebody signs up for a clinical trial without asking me a single question. They just said, I'll sign. And I'm like, no, you won't. You have to. If you are signing that quickly, then I haven't done my job. I haven't done my job to put enough skepticism in your brain to say, do I qualify for this? Is this the right thing for me? And especially, what are my treatment options? So yes, I think skepticism is good, but don't let skepticism close doors on you.
Right, a healthy skepticism. I got you. So, Black Americans, Black and brown folks are diagnosed with multiple myeloma roughly twice the rate as white Americans, and yet, we still remain dramatically underrepresented in clinical trials. Well, no. How does that happen, man? How does that happen?
So I put the total blame. I put the total blame of that situation on my colleagues. And I think, that is a doctor problem. Again, if you dial the way back machine, way back machine, it was our problem and their problem. Our problem as in Black people, and their problem being the medical establishment.
Okay.
But as we've become more empowered, we've become more educated, we have resources to gather information, and you see those numbers stick, despite the FDA, despite the NCI, and the National Cancer Institute, despite the CDC saying you need to put more diverse populations on clinical trials. Still, it remained absolutely static. Then that falls on physicians and sponsors for clinical trials. They don't see the importance of it. And so what had to, and my case in point is the Horizon clinical trial with the MMRF. So the Horizon 1 clinical trial uses a new myeloma drug called teclistamab for first, people with myeloma had first relapse. And we made a commitment to enroll diverse populations. We, talk to the physicians, talk to the hospitals, we talk to the research coordinators, we talk to the project managers, we have meetings all the time. We change the way we wrote the protocol, all more and set standards of who we wanted to enroll and when we wanted to enroll them, especially Black, brown people, and older people that are usually excluded from clinical trials. And historically, we would enroll, historically, it's like 5% Blacks. When we engaged all that, we engaged all those mechanisms, we enrolled 32% Blacks on the myeloma clinical trial, which is higher than the 20% of Blacks with myeloma in the United States. Now, did we go out and put up a billboard in Detroit saying enroll in the clinical trial? No. What did we do is we talked to the doctors that see Black and brown patients and said, this is really important. We made a cultural change. So don't blame Black and brown people for not being in clinical trials. I would never do that because it's not true. The ownership, we went from 8% to 32%, not by changing the minds of Black people, by changing the minds of the medical establishment.
That's heavy. That's heavy. So, when we, you said it so much. I'm gonna get you to go a little deeper, but that's heavy. What are we losing scientifically when Black patients aren't represented?
I mean, so one thing we know, this is what the majority of what of the lectures that I do is showing that with multiple myeloma, that Black people, Latino, Hispanic, white, Asian, and indigenous people are not the same when it comes to this cancer. Not just that the incidence is twice as high in Black people, but that Black people have less high-risk myeloma. The Black people, they present differently. They present at an earlier age. That they have, different mutations in the myeloma cells than white people, and that they, with equal access to care, they do as good, if not better, than white people. So can you do a clinical trial on a Black person and expect the same result in a white person? No. Can you do a trial in 99% white people and expect the Black person to have the same result? No, because they're different. And so what we're missing out on is two things. One, that if Black people and brown people are in clinical trials, we miss the safety signal. How do I know that if I give a Black person this drug, that it'll have the same result? Case in point, lenalidomide. Lenalidomide, the original clinical trials for lenalidomide, the treatment of myeloma, had 0.5% Blacks on it. So basically non-existent. One thing we learned over the years, drug was approved by the FDA way back then. This is 20 years ago. Approved by the FDA with low numbers of Blacks. And it took us 21 years for someone to write a paper to see that when Black people got lenalidomide, their skin got darker. Their palms of their hands got darker. The palms of their feet got darker. Doesn't happen to white people, it happens to Black and brown people. But it took 21 years for someone to write a paper on that. And why did it take 21 years? Because that trial that was done 20 years ago, more than that, 26 years ago, didn't include enough Black people. And a safety signal was missed. And so
I see what you did right now.
Yeah.
That's a real world example right there.
It's a real world example. And we have written papers and written white papers saying that we really do need to enroll those numbers in order to know. And we're doing it. I mean, obviously with the Horizon, we'll get much, if Black people, white people, Latino people, Asian people are all the same in that trial, I'll be the first one to celebrate. But if we find that there are, Black people having a different side effect or a different response, then we need to know that. And we can't know that without the participants being of diverse backgrounds.
Man, you got some bars right there, Dr. Cole. I I was speaking somewhere and you answered, it's almost like you already know the questions, which you don't, but you answered the next three things I really wanted to shine a light on. But I want to say that I had spoke somewhere and I was trying to get uh, our people to understand that if you got a, and I'm just saying arbitrarily a number, if you have a clinical trial with 30,000 participants and 25,000 of them are white and 5,000 are black, what I want our folks to understand is if they get the right efficacy, they eventually bring that drug to market. And once that drug comes to market, guess what? Who it don't benefit. But if you flip that around, it's basically it's basically what you were saying. You flip that around, now all those things, those different safety protocols will be more, I call it more precision medicine wise, relatable to Black and brown folks. So I appreciate you pointing that out. I guess what's, and I think you mentioned it earlier, but I just want to see what your reaction is to it. What keeps more people out of trials? Fear, money, transportation, or simply nobody asks?
Nobody asks.
Ooh.
And I don't even need to, I know that. And there was a study that was done, I think by the NCI a few years ago, that when offered a cancer clinical trial, Black people, Asian people, and Latino people were more likely to agree to a clinical trial than Caucasians. And it was like 70, 40.
Okay.
Less than half of white people want to go on a clinical trial. So then you would say, why in the world are there 0.4%, 0.5% Black people on a lenalidomide trial when white people are less likely to enroll in a clinical trial? And the reason is that they're not asked. They're not asked. And so so how do you fix that? What you fix is, and when everything else, all the other points that you said, remediable. If the doctor asks you about a clinical trial, you can then say, okay, let's talk about transportation. We're going to get transportation to be able to get you to the clinical trial. Most clinical trials offer that. If you say fear, that is the physician's job. That's the research, coordinator's job. That's everyone to assure your safety and make you feel safe. There is nothing that you mentioned that isn't already anticipated in the clinical trial.
What about that money?
Already has solutions, and even money. Yes, even money. That a lot of clinical trials these days give stipends. They give reimbursement for time that is lost. That they give hotel rooms or close by the clinic if it's multiple days. And so they want you in the clinical trial. They work towards that. The one thing that you can't affect that we have affected, but you can't affect, is being asked to be on a clinical trial. And that's, so my focus, what I am laser focused on is, I know we have solutions for all those other things that you mentioned. But my job is to really make sure that my colleagues ask everybody and see the value in asking everybody and knowing that people are different. And just because they don't come, just because they don't look like you, just because they don't talk like you, just because you may not share the same, first language, they don't live by you or have the same, social construct, does not negate them being on a clinical trial by any way, shape, or form. That you need to pivot different. And they teach you that in medical school, how to pivot different. And you have to get back into that.
Facts. Okay, so do you think doctors sometimes unintentionally decide who they think belongs in the clinical trial?
Yeah. So we know that people have unconscious bias.
Okay.
That we all have unconscious bias. I mean, I see someone taller than me. I'm 6'5". I see someone taller than me, and I'm like, that dude must play basketball.
I got
If
you.
you're if you're 6'7", I'm sorry. That's my unconscious bias. I mean, it kicks in, and I'm just
Right.
like, that dude must play basketball, and he probably doesn't. He probably doesn't. And the
Right.
likelihood, undoubtedly, is that he does.
Mm-hmm.
And so, but people walk around with these unconscious biases, and they can walk around with an unconscious bias, saying, this person doesn't want to be in a clinical trial, so I'm not going to even offer it. And that's the absolute wrong thing. That's the wrong thing. In the same way it's wrong for me to assume someone taller than me must play basketball, it is just as wrong for someone to say, oh, this person doesn't want to be in a clinical trial. This person probably doesn't have the social support. This person doesn't have this. The person doesn't have that. What you have to do is we do. I mean, almost every state medical society, almost every research program has a unconscious bias training to break that mold.
Got
And
you.
so that is because it's really important to break through that, because that's what holds people back from being on clinical trials, is that they're not asked. But also, I would say, I don't want to, the last thing I want to do is put pressure on people. But also, be like my grandmother is assert yourself. I mean,
Yes.
when a doctor, her doctor said, this is what we're gonna do tomorrow, I'm not gonna ask you, and she said, no, this is what I want to do. Ask your doctor about clinical trials, hands down. And if the doctor says, no, I don't have any clinical trials, then you ask, where are they? What is out there? Where, if you're just in the clinical trial, you're at a point in your disease, and if they don't offer it to you, it does not mean it doesn't exist. The likelihood is that it exists,
Right.
but
Just got
then,
to.
and you just have to. But the biggest thing is again, the ownership is on the physician and the providers to get their act together and start to give equal access to these clinical trials to everybody.
Got you. So, want to just say, and this is more on, no, I guess it is personal, but have you ever looked at a patient or looked at someone and thought this trial could really, really help them, but new life circumstances would probably maybe keep them from participating? I like the smile you got on your face.
Yeah. I mean, that there, does that happen? It definitely happens. I mean,
Okay.
and that's why we have shared decision making. I ask a patient, and I do. I mean, one thing I think that happens, and I think that is important, is that and I tell doctors, I say, know your patients, know who they are, be curious about where they come from, understand their social circumstances. I mean, they have cancer, everyone's scared, everyone's worried. But find out who do they talk to about their cancer, who do they talk to about their disease,
Right.
and you get an idea, you get a picture over time of what their social, what is their social circle. And then when you offer a clinical trial, you can work within that circle. If that circle includes, a tribal leader, like with indigenous people, you don't include them, it's not going to go anywhere. If they're, if there's an auntie that's part of that decision-making tree and they're not there, they don't hear me, then it may not go anywhere. And so knowing people and saying, bringing people with you to your appointment helps to empower you. My grandmother brought me to help empower her. And so, another set of ears. And so bringing people in. But yeah, it happens. I mean, when people say, I'm like, this clinical trial could really, work for you. And they say, circumstance X, Y, and Z, I don't even blink. I tell them that is, and I tell them, signing a consent form for a clinical trial, you're not getting married to me. We're not getting married. Anytime that you want out of the clinical trial, you can just say, I don't want it. And there's no repercussions. No, I don't get mad. I am more than anything happy that they said something. Because the last thing I want to do is have somebody on a clinical trial who doesn't want to be on it. That's a bit dangerous.
No, that makes perfect
sense. So if they say, I want to be up for clinical trial, no repercussions at all. None at all. If they say, I don't want to do the clinical trial, I don't even blink. I'm like, okay, you have the consent form, and we can always explore this in the future. And I think one thing that at least I do is that I make sure that I talk about clinical trials, to every patient. 99.9% of the time, we don't do the clinical trial. But I put that as an option. I tell my patients about the new things that have happened so they can hear over time that this drug is approved, that drug, this thing looks awesome, that thing looks awesome. You're getting closer to a cure. So that when I say clinical trial one day, it's not like they've heard it for the first time ever. They've heard it for the years that I've been taking care of them, and it's not a big shock. I hope that answers your question.
No, that definitely answered the question. So look, I'm gonna get to this space. I'm gonna switch gears a little bit. I need you to finish the bar. I'm gonna start the lyric. All right. So we're gonna play this real quick. The biggest mistake patients make is
saying no without considering.
Okay. All right.
Oh, well, let me.
I
got a couple.
I
got a couple. Can I keep going?
Yeah. We got look. Clinical trials.
Saying no. That's true. That's true.
Yeah, it's true.
Saying no without thinking about it.
Here go the other one. Clinical trials are not
dangerous. They help.
I love it. Okay. The future of myeloma research depends on
Black people being on clinical trials. That's how we cure. There is no cure until everybody is cured. Period.
All right, got you. Period. I got you. All right, so look, imagine. So I want you to. I could talk to you forever. We're almost out of time. But imagine every Black man in America living with multiple myeloma is listening to you. No doctors, no research, no PowerPoints, just you. What do you want them to know?
That the way that we can get to helping you individually, to helping people in your family that could get this disease in the near future, people that could have this disease in the future, not related to you, but in your community. Mm-hmm. The way to improve and cure this disease is to be part of the solution. Mm-hmm. And being part of the solution is enrolling in clinical trials, because it is safe. They take care of you. There is no better time. The clinical trials, the drugs that we have for myeloma are so good. It is incredibly competitive. It is hard the response rates for a lot of these drugs are 89, 90%. So that's a standard of care. Standard of care is way up here. And so you can't lose beyond a clinical trial. The worst thing you're going to get is a 98% response rate. And you could go on a drug and get 100%, 2%. Mm-hmm. So it is safe. It is effective these days. It will help you. It'll help potentially your family. It'll help your community.
Oh man, I got a little last personal question. Craig, if 20 years from now, when another Black physician stands where you stand today, what do you hope they never have to explain about race and clinical trials again?
Yeah, that's such. So what I hope that they don't lose is they don't, they have one hand in the history book to know that we constantly need to learn from the past, and they have one eye towards the horizon, and to know where we need to go. And so I hope that the person that comes after me has some awareness. I have a very clear awareness of where we were, but because that's how you learn. But also, I'm driving towards the future to make sure that we cure this disease for everybody. And that that hand on the book reminds me of the mission that's ahead. Because the last thing we want to do is to go from 0.5% to 30% back to 0.5. So having an awareness is very important, but also always striving for the future.
Man, Dr. Cole Craig, it's been an absolute pleasure. That was, when they say drop the mic, that was one of them drop the mic moments. Man, it's been an absolute pleasure having you on the show, and to just chop it up with me. It's so important for us to see people that look like us, and it's not me telling them, but a brother who's dedicated his entire life to this space of hematology and oncology, and in particular multiple myeloma. So from as a myeloma patient myself, and to the rest of the myeloma community that not only just doesn't look like me, but especially that looks like me, man, we thank you for all that you do, brother. And I really, really appreciate you coming on the show. I will let you say any last words, but I do got one last question after that. I'm gonna go ahead and let you,
I was gonna just say thank you for all that you're doing. I mean, this is what you're doing is a dream come true. Is that there years and years ago, we were looking, hoping, praying for someone that would occupy the space that you currently are there. And we asked a half dozen people, about 10, 15 years ago. And nothing happened. And the fact that you have jumped in there and you have done it with grace, intelligence, humor, make it accessible. Making it accessible to people is so important. So, it is a dream. What you're doing in Hip Hope Hooray is a dream that we've had for a long time that has come true. And I really appreciate that.
Oh, man. Thank you for the flowers. To God be the glory, I will definitely say. So yeah, man, look, I just got one last question. I hope this don't fall. I hope it falls where it needs to fall. But I got one last question. When you want to get hyped up, geeked up, psyched up, or just want to get in that mood of being inspired, give me one hip hop song that you might listen to. See, the man with all the doctorates, right? And I got him. He's stuck.
No. I have to say, there is so much. I love Ice Cube.
Okay.
And that is, and Ice Cube, because that was when I was in college and when I was in medical school. That is what helped drive me.
Okay.
And to this day, when I'm just trying to think which one would I pick on. But it would definitely be, something in the Ice Cube repertoire.
Okay. You got America's Most Wanted. You got Today Was a Good Day. I'll leave it open. We're gonna go with Ice Cube. I'll find something that we can put up on the site, because all my guests, whatever song they choose, I put it up on the site. and put their names to it. But Dr. Cole, once again, I appreciate you, my dude.
Yeah.
I
Well,
appreciate
thank
everything.
you.
I appreciate everything you do.
This is, like you said, this is what I love to talk about. And so, um, so I super, super appreciate that. And again, everything that you do.
Nah,
Very much so.
no worries. I want to give a shout out to my sponsors, Johnson & Johnson and Pfizer. And as I always like to say, peace out and keep 50 guessing.